Well, folks who listen to this show, they know I'm always happy when I'm hosting a first timer on Healthcare Unfiltered because this means that you're taking a chance on this humble, modest amateur podcast. And I appreciate Andrea coming on Healthcare Unfiltered.
Thank you. Thank you so much for having me. To me, this is an honor. I'm a listener, so
Oh, thank you. Thank you so much. Okay, well, I want to just make sure people know who you are, and obviously you're specialized in geo-oncology, but as you tell us who you are, maybe a bit about what got you interested in that field of medical oncology.
sure. My name is Andrea Apolo. I'm a medical oncologist at the National Cancer Institute in Bethesda, Maryland. And here I serve as head of the bladder cancer section for the GU malignancies branch. Genitourinary malignancy is my specialty, and I do bladder cancer, but I also do rare GU tumors with an interest in rare bladder histologies, rare kidney histologies. We see penile cancer. We also see rare testicular cancers. So basically, a lot of different GU tumors.
Uh-huh. What got you into geo?
So I think I would say my mentor did. When I was a fellow at Memorial Sloan Kettering in New York, I worked with Dr. Dean Bajorn, who did bladder cancer. And with that, I really was intrigued with the biology and how little we knew about the effective treatments that could potentially work in this tumor. And then I also thought that they were an underserved population in oncology that didn't really have a lot of advocates for themselves. I became very involved with the Bladder Cancer Advocacy Network, where they provide education for patients on bladder cancer. And also they have a think tank every year where I can get together with other GU specialists who are interested in bladder cancer and really talk about the science, talk about, how we can better treat our patients and better serve our patients. And, once you kind of started, I came to the NCI because I had a service commitment through the government where they had given me a scholarship back when I was in college, and I had to come back. And I worked here when I was in college. I worked in the lab. I worked for 3 summers here. And the service commitment is for every year that you get the scholarship, you come back and you work at the NIH. And I was like, that's like fantastic. And you can come back anytime. You can come back after you finish college, after you finish medical school, after you finish your residency. But I want to come back as a PI. I want to come back and make a big impactful difference and work as an oncologist because I knew they had a terrific oncology department. But they didn't have anybody working on bladder cancer. So when I reached out to them, they were like, well, can you just work on bladder cancer and start a bladder cancer program? And I was like, of course. Oh my God, that's like amazing. Sure. I don't know what to do, but I will go and I'll just kind of start working and figure things out as I went along. And it's a great group of physician scientists that work here. Everybody is doing some kind of translational research. There's a lot of lab involvement, which is really kind of fun. It's a unique environment to work in, that's for sure. As somebody who grew up in New York my whole life, I trained in the Bronx, went to college in the Bronx, went to medical school in the Bronx, did my training in Manhattan and at Cornell for residency, and then Memorial Sloan Kettering for fellowship. I never really trained outside of New York, so I trained in a lot of inner city hospitals. So this is a very different place, but it's a unique place, but it's a very special place, and I really love working here.
So are you mainly in clinic or are you do some lab work or you just collaborate with the lab folks?
So I do a little bit of everything. So I run a clinic. I have a clinic where I see patients. Most of the patients are enrolled in clinical trials. We do see standard of care patients also, and we do a lot of second opinions. That's something that we do a lot. So I'm very integrated in the community here, within the Maryland, DC, Virginia area, which is really great. We have a nice consortium. I also run a lab. I have a lab. I work with many scientists, but I myself have a lab. And we do a lot of translational work related to the clinical trials that I do. So I have a little, it's really a great, for me, it's like the awesome job, right? Because it's just like you get to ask the questions in the lab, do the translational work, really work with fantastic scientists that kind of help and contribute and really help guide kind of the basic part of it. I get to drive what the important clinical questions are and also run clinical trials. So it is really kind of a fun place to work because of that.
I have an entire chapter in my second book, The Cancer Journey, on second opinions. So that is the book you should recommend to all of your patients and families and everybody. But I have an entire chapter on second opinions because I think they're really important and critical.
I
So
think so
in
too. Yeah.
yeah, in the lab, I mean, what I have learned back in the day, long time ago, I spent some years in the lab, and you have to be like very focused in the lab. Like in the lab, what exactly are you doing in the lab? You can't be very broad, I guess, in the lab. You have to like just like
Yeah.
one or two things you're focused on.
And if there's something that I think they would criticize me for here at the NIH is that everybody's very focused. Everybody's working on one pathway, one molecule, and I'm totally not like that. So I'm like working on like 5 or 6 different things. And, everyone's like, you got to focus, one thing, work on, and I'm working on like a lot of different things. And not only in my lab, I'm also working with other labs that are working on other things, and we're collaborating with them, and we're spending time with them too. So we work on a lot of different things.
Yeah.
One of my interests is rare tumors, rare GU tumors. So, we have models that we're trying to build because we don't have good models for rare GU tumors. So we're trying to build models in order to do drug screens, test a lot of, especially these antibody drug conjugates that are so effective in bladder cancer and in other solid tumors and not solid tumors too. But it's, we're testing these in bladder cancer models. We're also trying to understand resistant mechanisms of these drugs. So, we have resistant cell lines that we've built, and we're trying to do in vivo models too. So it really is in line with what kind of I'm working with at the time. Like I was doing a lot of work with TKIs at some point, and I had a lot of research in TKIs. We had models that we were looking at the signaling pathway and what exactly was affected. So that is probably the biggest criticism I have, is that I'm not really like doing one thing. But maybe that's just me. So
No, I think it's. I don't know why you would be criticized for this. I think possibly, if I have to pontificate, I wonder if it is easier to get grant funding if, like you, when you're submitting, you're like, okay, for the past 5 years, I've been working on this damn pathway.
yeah.
And so people who are going to fund you, they say, oh my gosh, you spent 5 years working on this versus others. I'm
Right,
just
right.
assuming.
No, I understand that. Yeah, yeah, and I think that's fair. We do have support here to do our research, so we are in a way very privileged that we are given some our own funding, but we do also get outside funding, and we know how competitive it
Yeah.
is. And you're
Yeah.
right. If you are a world expert in this pathway, you're probably going to get that grant specific
Right.
for that
Right.
pathway that you're studying. Yeah.
So I've asked you to come on the show not only because I haven't had you before on the show, but also we're taping this towards the end of 2024. It's going to air before end of 2024, and as we reflect on so many advances in urothelial cancer, and it's probably fitting because in a few weeks after taping this episode, the world is going to be looking at ASCO GU in San Francisco. I can't believe how time flies by. To be honest, it's just like I don't know, it's depressing sometimes. But also, recently the ESMO meeting, you had an amazing, again, finding and a publication, all of this stuff, and we're going to talk about this. But what I want to, before we get to this, I want to try to help listeners understand where we are with urothelial cancer because things have really changed drastically. What help us all understand, like when do you think was I don't know, the tipping point where was there like an aha moment for the folks who are focused on urothelial and bladder cancer where like, you can always tell, gosh, this is really like before and after. You know how if you draw on a slide like a line, You say before this and after this. Is there such a moment in bladder cancer or urothelial cancer?
I think that when we saw that bladder cancer was responsive to checkpoint inhibitors, that was a huge moment in our field because we had only been given chemotherapy, and that's really kind of what worked. And we've tried, as someone who has done many clinical trials and has many negative clinical trials under my belt, I can tell you that we were knocking on people's doors and trying to find some kind of effective therapies because the overall survival for patients with metastatic disease was terrible. It was a year basically. So when we found that checkpoint inhibitors were active in bladder cancer, that was a huge turning point in our field. All of a sudden, like companies wanted to work with us, physicians who work with bladder cancer, and they were interested in us running clinical trials. They were interested in us trying new therapies in the lab. I mean, so this was a huge turning point for us. And
Was that by chance though? Was there some mechanistic way where folks started studying like checkpoint inhibitors?
Um, I, I think that there's a good rationale why it works, but I can't say that it was because of that. I mean, we saw, yeah, PD-L1 was
Yeah.
expressed in bladder tumors. It's a tumor that has TMB high. I mean, there's a lot of good rationale for why it works, but I think it was one of the tumors that where it was tested, and we were just seeing activity. And we started with atezolizumab, then we went on to pembrolizumab, nivolumab, durvalumab, avelumab. Like all of these agents were showing activity in post-platinum metastatic patients where really we had nothing. And I think that was a turning point, and then came the targeted therapies. We found EGFR as a target. That was like one of our first targeted therapy that we had, an FGFR3 inhibitor. Then we had the antibody drug conjugates. The antibody drug conjugates then were combined with immunotherapy, which was there. I think there was a good rationale. We combine chemo with immunotherapy. We see a little bit more activity. And that was a major turning point for bladder cancer, where the presentation at ESMO with enfortumab vedotin, which is an antibody drug conjugate, plus pembrolizumab, a checkpoint inhibitor combined, had a 70% response rate, an improvement in overall survival and this is like a 30% CR rate, like amazing responses, an improvement of overall survival for patients with metastatic bladder cancer compared to platinum-based therapy. It doubled it. It went from 16 months to almost 32 months. I mean, really, it doubled the overall survival for our patients, and it really just turned the field into this like area where there's so many clinical trials being done in bladder cancer now because we have effective therapies. So how can we better combine them? How can we better sequence them is a big question.
So we're gonna, as we think through this, I like to segment this into like, early stage and late stage disease because I do think they're obviously different, probably biologically. But when you think of before we get into how you approach metastatic or advanced disease, one of the tough things about conducting clinical trials, Andrea, and you're a trialist, is they take a long time between design until you actually finish and enroll and read and publish. And sometimes there are so many trials happening side by side that by the time your trial reads, maybe there's another trial that is going to read at the same time, and it becomes very difficult to interpret your trial because it didn't integrate the findings from the other trial that you didn't know the results of.
Yeah.
So, as a trialist, that you're spending your time doing this, is there any way that like, how do we handle this? Maybe there's no way. I don't know. I mean, I think it's an important question to address.
I think so too. And it's a great thing that trials are now being done and so many are ongoing and so many are positive. But it does make it more difficult for clinical trialists to plan 2, 3 steps ahead, thinking, okay, you have to not only think about what is the need, but what will be the need in 5 years or however long your trial takes? And will my questions still be relevant? Will the control arm that I'm using still be the right control arm? There's so many
Yeah.
different things that you have to think about now when you're designing a trial, and you have to think 4 or 5 steps ahead, because now trials are being designed, with a certain drug, like let's say like in the neoadjuvant setting, they're using platinum-based chemotherapy. I don't think that we're going to be using cisplatin-based chemotherapy in the neoadjuvant setting much, because now we have these antibody drug conjugates plus checkpoint inhibitors being tested, multiple trials being tested in the perioperative space. And I think that that's really probably going to be the standard of care. So it becomes really difficult to design trials at this point that are relevant, because you do have to think
Mhm.
3, 4 steps ahead.
Well, you brought it first, so brought it up first, which is early stage. Let's do early stage because you brought up the neoadjuvant therapy. So a patient walks in the door and you're convinced that they do not have metastatic disease, so they have an early stage disease. Um, how do you approach that individual? And if you are you able to give us a little bit of a glimpse whether there are some patients that you're able to not do an operation on and spare them a major surgery?
Yeah. So the majority of bladder cancer are actually non-muscle invasive. So non-muscle invasive are really predominantly seen by the urologist, and it kind of becomes a chronic disease because they have a high rate of recurrence, but not as high rate of progression, depending on how aggressive it is, how high grade it is. So non-muscle invasive disease are generally, you do a resection, a TURBT, you do intravesical therapy, you monitor them. There is now systemic therapy available. Pembrolizumab was tested. There was an improvement in outcomes. It was not a randomized study. It was a single arm study that showed some efficacy. So it is an option, but it's not used very much because, again, these patients are owned by urologists. They're really owned. That's who sees them. Now, when the patient is muscle invasive, so it's T2 or greater, that's when the medical oncologist gets involved because the patient needs systemic therapy. Neoadjuvant chemotherapy, specifically platinum-based chemotherapy, because that's what we've always given, has shown to improve survival in patients when they get it before they do their surgery. And the surgery is pretty radical. It's a huge surgery. You take the bladder out. It's a radical cystectomy. You take, for women, it's a total pelvic exenteration. You take the uterus, the fallopian tube, the ovaries out, part of the vagina out. For men, you take the prostate, seminal vesicles. It's a really big surgery. And then you reconstruct the bladder. There's several different options that you can do. You could do an ileal conduit, you could do a neobladder for reconstruction. So it's a huge surgery. And even after doing that, if the patient has high risk disease, which means they have persistent muscle invasive disease after they got chemotherapy, if they got chemotherapy in the neoadjuvant setting, or if they have T3 disease, at the get-go or greater, those patients are really high risk that even though they had this huge surgery, the cancer is going to come back, like more than 50%, like 60, 70%, depending on the age, that the cancer is going to come back. So after undergoing this huge surgery, and some of them even after undergoing chemotherapy. So there's a lot of need in terms of how to better improve the outcomes for these patients with specifically muscle invasive disease. But there's also a lot of research now on non-muscle invasive disease. But again, like I said, those are
Yeah.
predominantly owned by the urologist.
So for muscle invasive disease, you mentioned neoadjuvant therapy. You mentioned platinum-based neoadjuvant therapy, which is what we have used all the time. But earlier on, you think in a couple of years, probably we will not use chemotherapy as neoadjuvant. Is that what you think is going to happen?
I think so. So there's a lot of several trials ongoing right now that are randomized large phase 3 trials that are using antibody drug conjugates, such as enfortumab vedotin, in combination with a checkpoint inhibitor. And we have seen the super high responses that we saw in the metastatic setting. And I think that we're going to be seeing those really great responses also in the perioperative setting. So a lot of these studies are giving the combination in the neoadjuvant setting, and then also some of them are additionally are giving it in the adjuvant setting. So kind of a sandwich approach. You get neoadjuvant and adjuvant. And there's a lot of controversy about you're overtreating the patients, we're doing too much therapy. But that's the way the trials have been designed. And that was one of the issues with the Niagara study too, which was recently presented at ESMO, and it was a big presentation. It was a big deal. It was another presidential. So two presidentials in a row, basically. We had the EV-302 study with in the metastatic setting a year and a half ago. And then this year at ESMO 2024, we had the Niagara study, which was a randomized phase 3 trial where platinum-based chemotherapy, which is given in the neoadjuvant setting, was tested against the platinum-based chemotherapy plus durvalumab, which is a PD-L1 inhibitor. And it showed an improvement in overall survival, an improvement in event-free survival, an improvement in overall survival. When they counted all the patients, it also saw an improvement in overall the pathologic response rate. So effective therapy, and it's an evolving field as to kind of what therapy we're going to give now in the perioperative setting. So now that we have shown that there's a benefit to giving a checkpoint inhibitor early, but one another thing, they also gave it in the adjuvant setting. So they did the neoadjuvant, and then they gave it in the adjuvant setting. And that part was a little controversial. Like, do you really need to treat? What if the patients didn't respond pathologically, had persistent disease? Should you still be treating them with durvalumab? And what if they had a complete response? Do you still need to treat them with? So there's a lot of questions that are still kind of ongoing about that particular trial. But I think it was so important because it showed that it did improve outcomes for patients if you gave the immunotherapy early with the chemotherapy.
I mean, it's impossible to answer all of the questions.
Right.
I mean,
And it was already 1,000 patients,
but not only this, I mean, unless you have now another study where all patients get neoadjuvant and then they get randomized after a
Right.
cystectomy into adjuvant versus no adjuvant, I'm not sure how you can answer this definitively. And I'm not sure. I mean, do you think the field of bladder cancer is going to invest resources into that kind of question right now?
I think that will be something that will be done, but it will be done probably by an investigator in a cooperative group setting. I don't know if the pharma company necessarily needs to answer
So
that
it'll be
question.
10 years. Will be 10 years. Okay.
It'll be 10 years, yes.
Well, you mentioned cooperative groups. Now we're talking 10 years. So, bladder sparing surgery. And I asked that question because obviously it's a major surgery. You just highlighted how difficult that
Yeah.
surgery is. And obviously not every person is able to withstand the surgery. So, what's happening in the world of, not doing surgery at all?
Yeah, no, that's a really great question. And there's a lot of trials asking that question, incorporating combination systemic therapy, incorporating radiation, chemoradiation, incorporating biomarkers like ctDNA to see, well, what if they have a pathologic complete response and not a pathologic, but a clinical complete response, because you're not doing the surgery, you're assessing it
Right.
really cystoscope, and then they also have negative ctDNA. Can we just observe them and not have them undergo this huge surgery? So these trials are ongoing, and I think they're going to be super important because patients would prefer not to lose their bladder if possible. So that is something that we strive for. But because it's such an aggressive disease, it has been the standard of care forever. For as long as I've been on the field. So
Yeah. Yeah. And it's not, I mean, it's not only losing the bladder, it's just, I assume there's some more morbidity or mortality just simply from the operation. Okay, well, let's do metastatic disease because I think that is there's so much data out there, and obviously you're very active in this, and you publish on this and all that stuff. So help us understand a bit when a patient comes in with metastatic disease, how do you determine what to treat? When I was a fellow, the biggest advance, by the way, just so you know, Andrea, how old I am, the biggest advance was when gemcitabine and cisplatin was published in the JCO, and was that this was, but again, lots of things have happened. So a patient comes in the door, metastatic disease, what are you doing?
well, in all fairness, I think that was a very important paper. And
Yes, of course, yes.
Yeah, it was we had been using platinum-based chemotherapy for decades, and the
Ah,
standard of care for metastatic disease was Dosten or gemcitabine and cisplatin. And the study that you're referring to was kind of looking at, it was a non-inferiority study, and it showed that gemcitabine was as good in terms of toxicity and efficacy compared to Dosten, and we use both. So both are options. Actually, it wasn't using Dosten, it was using the classic NVAC in terms of the schedule. But you know, anyway, that was the standard of care. And there had been a lot of trials that tried to improve upon that by doing exactly what was done in the Niagara study, incorporating immunotherapy, either by itself or in combination with cisplatin-based chemotherapy, or even carboplatin-based chemotherapy, just like, in case the patient couldn't receive cisplatin, just platinum-based chemotherapy. And it failed to show overall survival. There had been several trials in combination with Pembro, in combination with durvalumab, in combination with atezolizumab, that failed to show survival benefit when an immune checkpoint was added to the platinum-based chemotherapy. So that was super disappointing, except when the Checkmate 901 study was presented, and that one added the nivolumab, but it added it to only cisplatin, not to carboplatin, and there did seem to be a modest improvement in overall survival. So because of that, and that was also presented at ESMO, to ESMO, so 2023, and it's now FDA approved because it did show a survival benefit. Again, modest. It was presented at the exact same time as the EV302. So basically, it got not a lot of press because it was not as impressive as the EV302 that doubled the
I
overall survival.
think one of them got the standing ovation and the other one did not, right? Was
Right,
that?
that's right. That's right. And I would have presented that one first and then the EV302 just in terms of sequence, but that's not the way it went. So, and I was a discussant for this. So, I had to.
It was tough to watch the second paper after this, to be honest. I'm not gonna lie. I mean, it was, I think in any other meeting, that paper would have gotten so much
Yes,
attention.
yes, yes.
Yeah.
And the I think the FDA they're very black and white. They're like it met its endpoint. It got FDA approved, right? How many people are using it and what setting would you use it? I don't think there's many settings you would use it right now because we have EV plus Pembro, which is a lot more active, the enfortumab vedotin plus pembrolizumab. So that's what I use in
Is
the
it
med.
easier to use? Is it like, I'm not a believer, by the way, that just because it's a target agent.
No, no, no.
Yeah.
You're absolutely right.
Yeah.
It has a lot to do with the toxicity, right? And
Yeah.
how easy
Yeah.
it is to give. And it's not bad. The EV's weekly. It's 2 weeks on, 1 week off when you give it with the Pembro. And you can adjust it, you can hold it. It's basically chemo. I know it's like,
Mhm. Mhm.
antibody drug conjugates, they've gotten a lot of press
That's
right now.
exactly what I said. I mean, just because it's targeted therapy to me, it
Right.
doesn't mean it's going to have no
Right, right.
toxicity.
So they're chemo, and we manage them. They do have some unique toxicities depending on the target. So this one is against Nectin-4, which is also present in the skin and the eye. So you do have some toxicities from that. So we've learned to manage it, but I think it's a pretty tolerable regimen. And I've had some reservations. Usually, like I've given chemo for a long time. Sometimes I start patients on a low dose. This is like for platinum or patients that don't look that good. And for EV plus Pembro, I've tried to do that, and my pharmacist says, let's just give them one dose because it's just like one dose, right? It's a short half-life. Let's see how they do with the full dose, and then we can dose reduce. And I've been doing that, and patients have been doing okay, So it's manageable in terms of holding and assessing toxicity week by week.
Yeah. So right now for frontline metastatic disease, it's EV Pembro for almost everyone. Is there anybody that you think you shouldn't give EV Pembro to frontline?
Um, right now, no, because I think it's a very effective therapy. And like I said, even the patients that have a pretty poor performance status, if I'm going to give them systemic, I mean, I'm not going to say there's some patients that are so frail that, I have some
Sure,
about whether we need to treat or not. And
sure.
but if it's because they're frail, because of their cancer, and there's a 90% chance or 70% chance that they're going to have tumor reduction. And there's another 20% chance they're going to have stable disease. I mean, EV plus pembro only had a less than 10% PD rate, progression rate. So that means that the patients that are getting it, are doing well. So if there's any way I can reduce that tumor burden and improve their performance status, then I give it to them. So right now, I don't have a lot of reservations about giving EV plus pembro. And we actually wrote an editorial about this because we want to make sure that there was a suggestion that a criterion should be developed similar to we have a cisplatin criterion, patients that have certain GFR shouldn't be using it. But I think right now we lack enough clinical data to develop that kind of criteria. And I think we need that experience besides the clinical trial, which, of course, enrolls only like the best patients. We also need real world data. How do people do with poor kidney function? How do people do? And biologically, there really shouldn't be a reason why we shouldn't be giving this to patients with poor kidney function. And I do it. I give it to patients with poor kidney function. And I think right now we need more clinical experience in order to really understand who those patients are that we probably shouldn't be giving it to. But right now, I basically give it to all the patients in the
Do you give it until disease progression?
Well, that's another question. So
Yes,
the
that's why I asked.
the toxicity is the neuropathy, right? That's one of the treatment limiting toxicities that there are. And it's, you have to kind of stay on top of it because it's sensory and motor neuropathy. And we don't know the right answer to how long to treat patients, but I don't think it's right to treat patients forever, right? And we can't because it's cumulative, and you have to at some point hold, reduce, take a break, take a holiday. So right now we're without data. We're just kind of treating patients until they develop toxicity. Then we hold, then we resume, and we don't reduce. I think we really need to do trials, prospective trials, where we give a limited number of cycles and then see, do you really need to treat the patient for even a year? Like, can you give them 4 or 6 months of therapy and then assess them? And if they do have a recurrence at that point only, then retreat them. We need to learn more about how to do
it. So I wonder, I wonder though, I mean, can you think of how you could possibly utilize liquid biopsies in making a decision in metastatic disease? This is not, we're not talking adjuvant or neoadjuvant. So it's metastatic disease. Is there an opportunity there to look at that and see if I can withhold therapy?
I think we don't know the answer to that, but I think that would be a great thing to ask. And it's being retrospectively looked at in a lot of the trials that have gone on. I'm looking at it in a couple of trials that I've done too, to see how early can you tell what do the dynamics mean if they go up and down? How does that correlate with the imaging? So that's
I just wonder if there's like a level of ctDNA, for example. I mean, in metastatic disease, if you hit, maybe you can give that break, and just if you get back to it, maybe you can resume or something.
I think it's a great question, and there's a lot of efforts right now ongoing for that. But it's a great question, and we need those kind of biomarkers. We don't have anything right now.
So let's go from that metastatic disease to what else about metastatic disease, and second line or still in first line, or what, we're still in metastatic disease.
So if the patient has not received platinum-based chemotherapy, to me, that's my second line. I go to second line platinum-based chemotherapy for the treatment. And then if they have an FGFR3 mutation, erdafitinib is a treatment option for the patients. Now we have an agnostic approval for TDXD for patients that are HER2 3+. And there's a large number of patients with bladder cancer that have HER2 positivity. Now, whether they're 3+, that's a smaller number, but that's an option now. Unfortunately, the sacituzumab phase 3 trial was negative. That's another antibody drug conjugate that targets TROP2 with a TOP1 inhibitor. And had shown response rates in single arm trials, 27-30% response in patients that were pretreated in the metastatic setting. But the phase 3 trial, we have not seen the data yet. But the phase 3 trial had a press release showing that it was negative, and they voluntarily withdrew its accelerated approval in the second line setting. So then that gives us one less treatment that we have available to offer patients. And I have used it, and I think it works, but they were testing it against Taxol. Now, Taxol is a chemotherapy that has worked in bladder cancer for years with a response rate ranging from 20 to 25%. So it is a treatment option for patients.
Yeah.
And I think it had a lot to do with toxicity. I haven't seen the data yet, but I think a lot of patients did not get GCSFs and growth factor support prophylaxis, and I think that may have been a reason why that was.
I was going to say it is the withdrawal. It sometimes doesn't happen like withdrawal voluntarily. So we're going to go back to the adjuvant and your paper and but before this, in metastatic disease, what's like on the horizon that you are kind of on the lookout for, maybe in the upcoming ASCO GU and ASCO, any of these ongoing papers that you're really looking forward to, whether they're yours or somebody else's?
I think seeing the activity of other antibody drug conjugates will be exciting, because at this point, the problem is that a lot of the antibody drug conjugates have the same payload. And, we need to find antibody drug conjugates that work in bladder cancer that have a different payload, because there's probably going to be resistance if you're using the same payload. So, but I am excited about a lot of the different antibody drug conjugates that are being tested right now in bladder cancer. And, I hope to see that data soon. And, I think sequencing will be important. Biomarkers will be important. The ctDNA data, like I mentioned, that's being tested right now retrospectively in a lot of the trials that have been done in the metastatic setting. So I think that those are all kind of important studies.
So at the latest ESMO meeting, you had a major presentation and a paper that was published in the New England Journal of Medicine. Can you just, Andrea, just highlight a little bit as to when did this even idea start? When was it conceived? I always like to highlight to my listeners and viewers the complexity of clinical trials and honestly also the time it takes. That yes, you published it in September 2024, but sometimes it could have been like 5, 6, 7 years until you got to this. So take us through the beginning of when this concept actually came to you and your colleagues, and how long it took you, what steps you went through until you execute on the trial.
Yeah, so it takes a long time, and I think of clinical trials as my children, because I've got
They
two
are
boys.
they are your children.
They take a lot of work. They're a huge investment. They're totally worth it. This trial, the concept started a long time ago, many years ago. So I started the trial in 2017. It takes at least 2 to 3 years.
Was that when the concept though?
No, that's when we started enrollment.
Right. Tell me when the concept came to your mind.
Like 3 years before that,
Right. So
I was
2014.
working, I was doing, there were 2 trials I was doing at the time. So I was doing the first in human studies of avelumab, which is a PD-L1 inhibitor. So we actually developed avelumab here at the NCI. We did the first human trials, and I was running the bladder cancer cohort, and I was seeing these responses, and I was like, oh my God, this is amazing. I think this was like 2013, maybe 2012. And I was like, we have to try this in earlier states of disease, right? And then I ran a trial with cabozantinib, nivolumab, and cabozantinib, nivolumab, nivolumab. Cabozantinib is a TKI, a tyrosine kinase inhibitor. And we were seeing, and it was a phase 1. So it was like, first time that we were doing these combinations. And they were just working like amazing. Like in kidney cancer, like, the first 6 patients that I put on, they all had a response. And I was like, oh my God, this is like amazing. And that kind of led to discussing it with the companies, and the companies were like, we're doing a phase 3, in kidney cancer. And of course they executed and finished their phase 3. And I was still kind of finishing up my phase 1 expansion cohorts. So that's when the concept came to me, and I was a young investigator in the cooperative, going to the cooperative group meetings, and I said, well, what about if we do it in the adjuvant setting after surgery? We're not doing anything right now, and I put my concept together, and everyone thought it was a great idea. And it was with pembrolizumab, and at that time, there wasn't other trials that were ongoing in the adjuvant setting, but it took a long time for it to kind of go through. It was a CTEP study. The CTEP approved it. It just takes a long time to develop the protocol. Everybody, you have to select the people that are going to help you develop the protocol, and go through the statistics, like what would make sense. Should we do a survival benefit, which I really wanted to do, but it was just going to take a lot longer. So we settled on a whole primary endpoint of disease-free survival and overall survival. I wanted to include upper tract patients. It's just very typical of me. I wanted to include like rare tumors as an exploratory cohort. They kind of like X'd a lot of those things. They were like, no, 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 and kind of cleaned it up. And so I went ahead and I started the trial in 2017. And when I started the trial, it took so long that an adjuvant study with atezolizumab, the IMvigor010 had already started, was accruing, and I was like, oh man, and then as soon as I don't know, 6 months, maybe almost a year after I started mine, they started enrolling in the Checkmate 274. Now, Checkmate 274 finished, got FDA approval, and we were still enrolling, and we had to stop enrolling in our trial because cooperative groups just take forever.
Which one was the check made to
That was the nivolumab, the adjuvant nivolumab. So the adjuvant atezolizumab study was negative, and we were shocked. I was like, oh man, that's terrible. It set a terrible precedent for my trial. Like, is it not good? What does that mean? And we weren't sure. And then the 274 data, the Checkmate 274 with adjuvant nivolumab came out, and that showed an improvement in disease-free survival. It doubled the disease-free survival. And I was like, oh wow, that's great. But we were 96% accrued. We had to accrue 740 patients. We had 702 patients. The day that became FDA approved, and it became FDA approved pretty quickly after the data came out, we had to stop enrollment. So we stopped enrollment. We were 96% accrued. And the data that I presented at ESMO was the disease-free survival data that with the 702 patients. And again, we showed a doubling of the disease-free survival. So very consistent with what we had seen with nivolumab. And that was against placebo. So ours was against observation. And I'll tell you why I was really concerned that this study was going to be negative, was because as soon as nivolumab got approved, I got a swarm of emails from people in the observation group, providers, and the research assistants from sites, because this was open in like over 200 sites. And same thing, our patient is dropping out, they're going to get nivolumab. And I was like, well, they don't have to drop out. We can still follow them. I'd like them to still be part of the study. No, they don't want to come back for the follow-up. It's too much trouble.
Wow.
So I was like, oh no. And then it just kept on coming. And I was like begging them, don't drop off. Just stay on.
There was no crossover in your study?
No, there was no crossover. It was
Did patients in your trial receive neoadjuvant therapy?
Yes, half of them did. Half of them received platinum-based chemotherapy, the other half didn't. So very consistent with kind of what happens in real world setting. So I thought my trial was going to be negative. Like I was just like, oh, there's no way. And then when I looked at the data, I was blown away that it was a doubling of the disease-free survival. Like it was really, really impressive. And then I wanted to look at the overall survival. And they're like, you can't look at the overall survival. It hasn't met the event rates. And I was like, well, I want to see it. And I'm the PI, and then you realize that as a PI you don't have as much power as you think you do. But they showed it to me, and I said, well, I have to report it. I saw it. It didn't meet the pre-specified overall survival benefit. And they're like, you're going to show it, but it's it's not good to show immature data because people are going to then make conclusions about it and it's not mature. And I was like, I know, but it's important to me as an investigator. I always want to see the data. So I showed the data, and of course, people were like, well, what does that mean? It sometimes draws a lot of conclusions when in fact, it's, I don't even, once we even reach the event numbers, I don't know if we're going to show an overall survival benefit because we had such a large group of patients moving on and withdrawing from the trial to
Right.
receive nivolumab.
No. Did Nivo show survival benefit or just disease-free survival?
So it hasn't yet. There was a study that there was an update to the study that was presented earlier this year that showed a trend toward an overall survival benefit, which was really nice to see that. We hadn't seen the survival data, and we were like, what does it mean if there's a DFS benefit and there's not an OS benefit? As an investigator, that was really important to me. So that's why I made it a co-primary endpoint. So they did show it, and there was a trend. It still wasn't, they hadn't met the number of events, so it wasn't statistically significant, but it was trending toward an improvement in overall survival for the patients receiving adjuvant nivolumab.
Is this your first author NEJM paper?
Oh my God, yes. This was huge. Yeah.
So I have two things for you. Number one is million congratulations. Number two, I hate to break the news to you. It's kind of downhill from here. I don't think, I mean, you may get other papers, but the problem, once you get to this paper, now your assumption that every paper is going to get to the NEJM, but it's not going to happen.
I don't have that assumption. I know how it is. Yeah. I
How
mean,
did it
as someone,
feel? How did it feel when you
oh,
got the acceptance letter?
I was blown away. Well, first of all, I asked if they would be okay with me submitting it, and
You emailed the
I emailed
editor-in-chief.
the editors, and I said, would it be okay if I submitted it? Would you be interested? And they wrote back within minutes, and they said yes. And I was like, he said they would be interested.
But you did that, you sent them that note in the summer, like before ESMO, right?
That's right. It was before ESMO. That's right. Yeah. Yeah.
Okay. And did you get a lot of reviewers' comments, or like about like 5 pages of reviewers' comments? Was it like easy
Oh,
to
wow. The review
revise?
process was very complex. I think at some point I had 96 queries. And, I was like, okay, 98, like, what is this? And like half of them were statistical. So I needed my statistician to be online helping me kind of answer these questions. So it's such a huge effort. So I had two statisticians, a data manager, really helping me answer a lot of these queries. It was a lot of work. And we were meeting a deadline because I asked them if they would do a concurrent publication with my presentation at ESMO, and they said yes, but you have to get it in a certain time. So they asked the reviewers to do an expedited review. I think they gave the reviewers 10 days. And
Wow.
then, we had to reply within like a couple of days of that. And then there was another set of reviews. So it was very time consuming, but very worth it. And I'm very grateful. And what an honor to have a New England Journal publications.
Congratulations. This is really amazing and could have happened to a better person. So really, congratulations. It's wonderful. So why do you think we're seeing a bit of difference between these checkpoints? Like why the atezo is negative, the nivo is positive, the pembro is positive. For all practical purposes, the pembro probably won't see survival benefit because of the dropout that you just mentioned. Nivo maybe. I mean, is there actual like why? I mean, I don't get it.
I don't get it either. I couldn't tell you.
What's the difference between why like
I've
atezo
used
and pembro? Like what's going to
So
be the
I've
difference?
used atezolizumab. I've used durvalumab in practice. I used avelumab. I mean, we developed avelumab. These are very effective treatments.
Right.
So why were they negative? You can argue it was against observation. It was dropouts. It's hard to say. Some people say the PD ones are more effective than the PDL ones. I don't
I
know if
mean, I
that's
wonder if it's the design of the study or how you define
I
events or like I don't
So
know.
I think so because when we were looking at how we defined events, it was not exactly the same
Yeah.
as how they defined events. And we actually, so the FDA had reached out to me because I wear a lot of hats, and I also I work with CTIP, and the FDAs are my colleagues, and they had asked me to do a workshop, to help run a workshop in defining endpoints, just in adjuvant trials in bladder and kidney cancer. And we did that. That was back in 2000, I want to say 18. And there were all these like debates about what you count as an event, what is actually like disease progression, like when you measure it radiologically, like what do you count? Like, is there a new little nodule there? Are you going to count that as disease? Should you biopsy? Should you wait till it grows? There were all these questions that we had. So we developed like a white paper, consensus paper as to kind of how we would count events in disease-free survival outcomes, and radiologically, how would we assess them? So, and there's a lot of variability within trials, and the FDA didn't want to be prescriptive, but they just kind of wanted to give guidelines
Yeah.
for trial development.
In your paper, did you see the benefit regardless of whether patients receive neoadjuvant versus no neoadjuvant?
Yeah, I saw it in both, and I was thinking that we would see the most benefit in the people that received the platinum-based chemotherapy. Well, we saw the benefit. There was no difference.
Yeah. So, okay, so right now, a patient comes in the door, essentially muscle invasive disease. You are going to give neoadjuvant therapy, I presume, and then they're going to undergo surgery. And then after that, you can flip of a coin, do Pembro or Nivo. I'm sure you're going to pick Pembro. It's the one was used. But is there, I mean, are people, I hate cross-trial comparisons, believe me, I'm the first one to admit, but are people trying to figure out, are there patients that you benefit from Nivo versus Pembro, or pretty much it's honestly a flip of a coin, insurance decides, whatever?
I think they're both effective active drugs.
Yeah.
I know Nivo, the study was done every 2 weeks, and when I give it in the adjuvant setting, I give it every 4 weeks. The Pembro, we did the study with the 3-week cycles every 3 weeks, but when I give it now in the adjuvant setting, I give it 6 weeks. So I like the 6-week schedule because it just gives patients a little bit more time to themselves without having to come and see us. So, I mean, I like that benefit to it. So I give Pembro, and of course I'm totally biased because I ran the trial, but
Yeah.
I saw
Well,
the.
of course you have to. But maybe my last couple of questions, Andrea. So what's next? I mean, oftentimes trialists and investigators, they build upon their latest study, latest findings, recognizing that, it may take you maybe another 5, 6 years to execute on a trial, but you did this trial, it's the adjuvant setting, you showed the positive results, it's published. Are you trying to take that next and trying to see what you can build from this study, or are you just going to a completely different type of a study right now?
Well, I think that this study is so important because it kind of lays the foundation of the activity in the adjuvant setting. And like I said, a lot of the trials that are being conducted right now are doing the sandwich approach. They're doing neoadjuvant and they're doing adjuvant. So knowing the benefit of one component of it, again, cross-trial comparisons when it becomes available, but at least knowing that as a backbone will be really important. There's the EV plus Pembro study that's ongoing. There's a trial with pembrolizumab plus cisplatin and gemcitabine. So there's a lot of perioperative studies ongoing. And how much therapy should we give patients in the perioperative state, neoadjuvant or adjuvant, is a unanswered question that we need to figure out, because our tendency is to overtreat patients because we want to cure them. And, but maybe we don't need to overtreat some patients, but some patients actually need more therapy. So we need to figure out the right patients. And I think incorporating ctDNA in this setting is going to be really important, so we can best figure out who needs the treatment intensification and who needs the treatment discontinuation.
It would be great. I mean, look, by definition, adjuvant therapy, we're overtreating people. In any disease, when you give adjuvant therapy, you're treating pretty much everybody to save the lives of few with the adjuvant therapy. So anytime you're able to de-escalate, it's a welcome thing for patients.
And that's why these trials are so large.
Yeah, yeah. Anything I should have asked you that I completely forgot or glanced over and I completely missed?
I don't think so. You're a great interviewer. So I think we covered all of bladder cancer.
It's like a primer, like everybody who has an interest in bladder cancer, this is going to be We're gonna have this as the problem is I can't tape those fast enough. It's crazy. I'm not joking. Like
That's
it's
great.
because you have a lot. I mean, it's a good thing. You have a lot of these advances between kidney, bladder, prostate, and everything. And then, but this was really for me was it was just so good not only to see the fact that there are positive results, but the fact that you, as an investigator, you've seen the fruit of your labor. It was very nice to see, and it was important to share with listeners and viewers across the country.
Well, thank you so much for inviting me. Like I said, I'm a fan, I'm a listener, so it's
Thank
great
you.
to be here. Thank you.
Anybody that is willing to tune into the podcast is always. Now you earned the T-shirt. So off the record, you'll tell me where to send the T-shirt because you have to get the Healthcare Unfiltered T-shirt.
Perfect. Sounds
Thank
good.
you so much, Dr. Andrea Apolo on Healthcare Unfiltered. Thank you.